Yes, well, Mr. B is a classic major vascular patient that we see. He's elderly, aged 81. He has renal impairment. He has some respiratory disease. And he's also, in this instance, anemic with a hemoglobin concentration of round about 100 grams per litre.
Changes in blood pressure during anaesthesia can be driven by a number of factors. How would you target interventions intended to restore blood pressure and flow?
Well, the effect of propofol in this particular patient was not profound, but it was an effect on changes in stroke volume, and this was driving the relatively modest pressure change that we saw in this patient. Now, if it is due to a change in stroke volume, then the intervention is clearly different from one where the change is due to a fall in systemic vascular resistance. In the former case, a change in stroke volume, a fall in stroke volume driving the fall in blood pressure will be treated by adjustment of depth of anaesthesia, and if we have evidence that the patient is fluid depleted by stroke volume variation, giving the patient fluid and then perhaps supplementing that with an inotrope such as ephedrine. If, on the other hand, the fall is due to a change in systemic vascular resistance, then a drug such as metaraminol might be appropriate, but it cannot and should not be used as a bland treatment of all falls in blood pressure, as is commonly the case.
What might have been the response to hypertension during anaesthesia if the data from the LiDCO Rapid and the BIS monitor were not available?
Well, in the absence of those monitors, most anaesthetists would treat a fall in blood pressure by a quick fix drug such as metaraminol, which is great at increasing the blood pressure, but particularly if you look at what's happening with the LiDCO Rapid, it's only happening by an increase in systemic vascular resistance, often accompanied by a reduction in stroke volume and a reduction in heart rate sometimes, therefore reducing cardiac output. Hardly an appropriate intervention.
What are your triggers for giving fluid intraoperatively?
Having made sure that the patient is optimally anaesthetised, as mentioned earlier, I tend just to give colloid boluses to maintain the stroke volume variation between about 5 and 10%. I also give additional maintenance fluids, which all patients require, whether they're having surgery or not, which is basically 2 to 2.5 mils per kilogram per hour of 0.18% sodium chloride and 4% glucose.
And what are your triggers for giving blood intraoperatively?
Well, I think it's a very interesting question. Nobody has come across a universally accepted transfusion trigger. For example, in major cardiac surgery, often patients are allowed to drop their hemoglobins to 80 to 90 grams per litre, which of course would require a high cardiac output to achieve the usual goal-directed therapy. I don't look at it this way. I look at my individual patient, and I'm quite happy with patients with a hemoglobin of 90 grams per litre, for example. But if during surgery, having maintained all other parameters within the normal range, the cerebral oxygenation using the INVOS cerebral oximeter starts to decline by more than 10%, I found in almost every case that giving blood to these patients actually restores or reverses the drop in cerebral oxygenation. What that suggests to me is that the patient at that hemoglobin level, despite normal blood flow, cannot maintain the oxygen supply-demand balance in the brain and possibly elsewhere. However, I would not transfuse a patient if the hemoglobin was more than 100 grams per litre.
How is a fluid challenge given, and how do you monitor the subsequent response?
Well, I basically, apart from the maintenance fluid as mentioned, give colloid boluses to patients if their stroke volume variation is outside what is considered to be the normal range, that's 5 to 10%. So I would give, for example, in a 60 to 70 kilogram patient, about 200 mils of colloid, and this would be given using a 50 ml syringe and putting that fluid challenge in a very short, as short a period of time as possible, say over 1 minute to 90 seconds, and assessing that response by changes, for example, reduction in stroke volume variation. And if it comes back into the normal range, that's a successful fluid challenge. If it's still high, then I might repeat that. The important point to mention here is the fluid challenge must be exactly that. It must be given over a relatively short period of time, 1 minute, 90 seconds, not 10 minutes, 15 minutes.
What do you feel is the trade-off between fluid challenge and hemodilution?
I think that's a very important point. Most anaesthetists forget about the effect of their fluids on hemodilution. Now, when we're giving a fluid challenge, we're expecting stroke volume, say, to increase by, if we're lucky, up to 10%. If you're giving fluids to the patient, colloids for example, and you're getting an increase in stroke volume of, say, 5%, but at the same time, you're actually getting a hemodilution, reducing the hemoglobin content of the blood by more than 5%, you're actually reducing oxygen delivery. This clearly confers no benefit to the patient.
What are the advantages for the high-risk patient?
Well, I think the combination, obviously, of increased surgical techniques, but at the same time, our anaesthetic intraoperative management has improved the outcome of our peripheral vascular surgical patients. As mentioned, we are undertaking peripheral vascular surgery in high-risk patients who are often diabetics. And our excellent diabetologists have sat up and taken notice that these patients are now doing a lot better than they were doing 5 or 10 years ago. And certainly using this type of monitoring has meant the patients are much more stable intraoperatively and postoperatively. There is no need for them to go back to a high dependency unit or intensive care unit where they traditionally would have gone. Often those beds are not available anyway, but they're not required anymore due to the improved management intraoperatively. This, of course, has got resource implications, and it also means that these patients can go back to a general ward specialising in vascular surgical patients.
The monitoring of patient parameters is evolving rapidly. How would you like to see this develop, and how can it benefit patients?
Well, I think the use of combined monitoring using LiDCO, BIS and cerebral oximetry technology has allowed us to individualise goal-directed therapy. Goal-directed therapy, to my mind, is no longer based on population controls with figures almost clutched out of the air, the 600 mils mentioned earlier. It is based on what the individual patient has been doing prior to surgery and trying to maintain that value. This is now possible with the combined use of LiDCO, BIS and cerebral oximetry technology.